Hello everyone, I'm delighted to be here today to talk about infectious disease biomarkers in the UK Biobank. Over the next 10 minutes, I'll outline some of the challenges we face when trying to measure infections for research and consider how infectious biomarkers can potentially address some of those challenges. I'll also describe a new study which we're planning using infectious biomarkers in the UK Biobank data and briefly touch on future directions for this area. So in terms of challenges, one major issue is the spectrum of severity we see with infections, which range from asymptomatic infection all the way up to severe illness and death. And if we want to use research definitions based on clinical diagnoses, that relies upon, firstly, someone being symptomatic, but also having sufficiently severe illness to present to medical care, get a clinical diagnosis, which gets into their GP or hospital record. So these definitions lack sensitivity, and they're also often not very specific for particular organisms. So another approach would be to take specific laboratory-confirmed definitions based on testing for organisms, using, for example, PCR or cultures. However, these types of definitions then require both access to an appropriate test, but also done in a timely fashion. And obviously, the transient nature of many infections means that that's not always possible. So timeliness of testing is a challenge. So what we need is new definitions or new measures of infections that circumvent some of these issues. And that's where serum antibodies come in. Thinking firstly, before I get into details about antibodies, thinking more broadly about potential solutions, one thing we can do is to triangulate data from across different types of research studies using different data sources. So we can do studies using electronic health records, which are very large, powerful data sets, generalizable to real-world populations. And when we can combine those results with results from cohort data on more selected populations like UK Biobank, but with deep phenotyping. So either doing these studies in parallel or using linked data to combine them, we can start to get at investigating infections of different severities, different types of infections, at different timings of infections, for example. But what I want to focus on in this talk is measuring serum antibodies. And antibodies have a major advantage in that they capture prior infections regardless of someone's symptom status, regardless of their health-seeking behavior, and regardless of the timeliness of testing. So what they provide is a historical record, really, of exposure to infections over the life course. They're obviously specific to particular infections, so we've got improved specificity of definitions, which is important when we're thinking about targeted interventions, such as vaccines, for example. Using antibodies gives us a more sensitive definition to reduce misclassification and potentially increase the power of our study. We're not just talking about seropositivity versus being seronegative, but using quantitative assays enables us to calculate the titer of antibodies so we can quantify the immune response and look at biological gradients, for example, in epidemiological studies. And using multiplex serology, where we test for antibodies to multiple infections, enables us to look at different combinations of infections and calculate indices of pathogen burden. I've also touched briefly on the fact that we can investigate historical exposures. So many of these infections occur in childhood, and really, it's very hard to get good data on them in other ways. There are rarely accurate historical records. Participant recall can be problematic. So infectious biomarkers, as exemplified by serum antibodies, have got some real value to help us to do better research on infections, whether that's research into infectious risk factors, whether it's research into interventions such as vaccines or treatments, or whether we're thinking about complications of infections. And I think the COVID-19 pandemic has really demonstrated links between infections and other longer-term health problems, including exacerbating or triggering other diseases such as cardiovascular disease or other non-communicable diseases. Infectious biomarkers help us to do improved research into interventions to both prevent and treat infections directly, as well as some of these longer-term consequences. And ultimately, the goal is to use them to improve population health. I'd like to turn now to a research question which we're asking in UK Biobank, which is how infectious burden affects the risk of some major non-communicable diseases. And we're looking at quite broad categories of diseases, including cardiovascular diseases, metabolic disease, neurodegenerative conditions, mental health conditions, and also looking at combinations of diseases leading to frailty and multimorbidity. What's the background to this? Well, I think it's increasingly recognized that, so say in the past, infections and NCDs were considered to be quite different things. We increasingly recognize the links between these different entities. And a recent modeling study showed, using the global burden of disease data, showed that infectious diseases are actually responsible for around 130 million disability-adjusted life years due to NCDs. So that's around 8.4% of the total. This was largely based on looking at relationships between oncogenic viruses and cancers, so it's likely that this is an underestimate when we consider all of the other potential NCD outcomes. There are plausible biological mechanisms for these outcomes, including systemic inflammation and vascular mechanisms. And I think understanding these questions is of really major public health importance, because if we could prevent and treat some of these infections, could it potentially reduce the burden of NCDs? So in our study, what we're planning to do is to test 50,000 randomly selected serum samples. These are samples taken from UK Biobank participants at baseline. We're going to test them using a multiplex quantitative assay, which I'll talk a bit more about in a moment. We're also capturing patient-reported data on infections to try to get at some of those infections that don't present to medical care. And we'll also use electronic health records to refine our infection phenotypes. Our outcome data will come from linked hospital, GP records, various streams of self-reported health data and mortality data to help us define NCD outcomes. In terms of the multiplex assay, this assay measures up to 46 antigens from 20 pathogens. So it's a major advantage we can test these antigens simultaneously at scale. The way that it works, in brief, it's shown on the left here, but these antigens are expressed as GST-tagged fusion proteins and coupled to magnetic Luminex beads. Serum antibodies these are taken from the samples from UK Biobank participants, are then mixed with the antigen-loaded bead sets, and primary antibodies are detected using labeled secondary antibodies, and we can then incubate them with a reported dye to quantify the formed immunocomplexes. Here are some results from the infectious disease pilot study, which tested around 10,000 serum samples. So you can see on the left, we can produce some nice descriptive data looking at the age and sex-specific prevalence of seropositivity across different infectious agents. On the right-hand side, we've got an analytical study where we used UK Biobank pilot data to look at quantitative antibody titers and the cumulative cardiovascular disease hazard across a number of different infectious agents. That study was done using 10,000 samples. What we hope in our new study is that the much larger sample size, we'll have 60,000 samples in total, will deliver new insights into the relationships between infections and non-communicable diseases and help us to characterize population subgroups at risk for potential targeting of interventions. Our research will also generate a novel resource for use in future research of infectious diseases. And I think there's a few potential future directions. I mean, we would love to test more samples in the future, which would offer unprecedented power to look at these relationships and identify subgroups at risk. At the moment, we're talking about analysing data from baseline, and ideally, we would be able to measure repeated measures to capture the dynamic nature of the immune response, especially to chronic infections such as herpes viruses, where you have cycles of latency and reactivation. And in future, we could expand the panel further to study different specific infections and combinations of pathogens in relation to other health outcomes. In closing then, I'd like to thank Open Philanthropy, who are kindly funding this project, Tim Waterbaugh and colleagues at the German Cancer Research Centre are testing the samples. And thank you to my funders, collaborators and UK Biobank participants. Thank you.